Hi everyone, I'm Don Smith for Clark TV 36 and our Clark Media. We are on location at the Atlantic Health System North Pavilion here in Clark. We are here today to talk about heart health, and joining us is Dr. Robert Fishberg. How are you, Doc?
I'm fantastic. Thank you so much.
Very good. So let's get a
little.
little.
It's great to be here.
Yeah, let's get a little background on you, Doc. We're part of the Associates in Cardiovascular Disease here at the Atlantic Health System North Pavilion. So
Yeah.
give us your background.
I was a resident at Overlook Hospital, chief resident, and I did my cardiology in Connecticut. I came back in 1989. I've been practicing in the area since 1989, and I actually live in the area. I live in Westfield, and I've been in Clark for many years as a cardiologist. So I'm part of a large medical group, Atlanta Medical Group, and my group in it is Associates Cardiovascular Disease, with offices in Clark, in Springfield, and New Providence. And we cover the gamut of cardiology. My focus is on prevention. So I'm a preventive cardiologist. I'm boarded in cardiology and nuclear medicine, but I do stress tests, echocardiography. I'm also boarded in clinical lipidology. So I have a very strong interest in lipids and prevention. And one of the things I like working here in Clark is in this pavilion, I have access to, we have a clinical lab here. We're able to see patients. We have stress testing facilities. And we also have ability to do CAT scans to look for people who have early signs of atherosclerosis. Mm-hmm. Mm-hmm. And I think it's really important to, when you see people, to try to assess what their risk is. And a lot of people will come in, they have a strong family history of heart disease, and they're worried, their cholesterol is low elevated, are they at risk for a heart attack? So I take this very seriously, and it's my job is to try to help them prevent them from having a heart attack. So one of the things we do is try to assess their risk. And heart disease is progressive, and some people will develop, if they have a familial form of heart disease, they actually may start developing plaque at a very, very early age.
So let's get into this a little bit, Doc. So when would you suggest that somebody begins to regularly see a cardiologist? Is it based on your family history, and then you can kind of judge on that, or is there a benchmark of age that maybe someone should start thinking about?
I think that everyone should have a primary care physician, number one. Mm-hmm. And it's really the primary care physician should really be your point of care. You shouldn't be running around looking for specialists. So everyone should have a primary care physician that's you're comfortable with. And one of the things at Atlantic Health, we're blessed with a great group of primary care physicians, whether internal medicine or family practice. And right here in Clark, very close to this location, we have a group of great family practitioners. Also down in Westfield, in Union, really all over this area. And that's where you start with. So I spent a lot of time teaching residents, medical residents, trying to help with the primary care physicians as to when is the right time to refer to a cardiologist. Mm-hmm. And a lot of tests we're talking about, they could be doing too. But I think what's really important is, if you have a strong family history, if your cholesterol's elevated, that's when you should think about looking at the risk. And again, everything starts with lifestyle. Exercise and diet is really important. So everyone should be, walking, a half hour a day if possible. Everyone should be on a low fat, low saturated fat, low cholesterol, low saturated fat diet. All that's really important. You can't wait to see a cardiologist to decide to start eating healthy. So that's the place to start. But when I see someone, it's often someone like you maybe,
yeah,
who's young.
Young, okay, yeah. I like that, Doc. I like that, young.
Who's young, who's yeah. saying, am I at risk? Because again, in this area, you hear lots of stories of people who've had heart attacks.
This is true.
Who are feeling perfectly healthy. Mm-hmm. And many people have heart attacks. The first sign of a problem is when they have their attack.
When they have the attack, yeah.
So, I'm very interested in prevention of heart disease, and particularly if you have a family history of heart disease. I'm very interested in familial hypercholesterolemia, which is a disorder that occurs about 1 in 250. But there's also some other genetic disorders. One is, I'm interested in lipoprotein A, which is a protein in the blood that also increases the risk for heart disease. But when you think about heart disease, it could actually starting at the first decade, and it progresses. And again, it's a silent killer. So you're not going to even know you have a problem sometimes until you get to later in life. But the plaque progresses. So you can't wait until you're 40 years old to do something about it. If someone's at risk, you want to know early. When to treat.
So you can get treatment and try to remedy the issue. So
exactly.
So I have a question for you, Doc. When you talk about plaque, where does that come from? For those who may not know, how does that build up in your blood vessel?
So plaque is something that actually progresses from early life. And it starts off sometimes as fatty infiltration from lipids, but also it could be involved with calcium, with thrombus. And as you get older, the plaque could get more complex, become from a fatty streak to a fibrous plaque to a complicated plaque. And when you get to a complicated plaque, that's when you're at risk for having an acute coronary event, which could be unstable angina, could be a myocardial infarction, or it could be sudden death. So again, my goal is to try to prevent someone from ever reaching this stage of a complicated plaque.
And as you mentioned, some of that is exercise, your diet, and these preventative things.
Everything starts with prevention, with exercise and diet. Right. But again, you have to be aware of what your risk factors are. So everyone should be aware of what their cholesterol level is, what their blood pressure is, and you like your LDL cholesterol, if possible, less than 100. You want your blood pressure less than 130/80.
And the LDL is what they call kind of the...
LDL is a bad cholesterol.
I want you to say it, not me.
HDL is a good cholesterol.
Okay.
But you want your LDL as low as possible.
Okay.
Again, a lot of patients come in, they have their LDLs of 130, 140, 150, and they say, well, do I have to take a medication for that? So one of the things that we do is, assess someone's risk. Again, diet and exercise often is always the first thing you do, but when I see someone and I assess their risk, I may do a series of blood tests. I may look at their cholesterol again, look at particles, look at lipoprotein A, ApoB, do the cholesterol level again. But often I'll do a test called a calcium score. A calcium score it's a CAT scan of the chest, and again, it doesn't have that much radiation. It has a small amount of radiation. The new CAT scanners have very little radiation, so it's very, very safe. And it actually looks at the coronaries and see if there's calcium in the coronaries. And calcium shows up as a white speck. When you're born, you have no plaque in the coronaries. You have no calcium. As you get older, you may develop more plaque, and as part of plaque, you'll see calcium. So it gives you a insight into someone's risk. The more calcium, the more risk. So if I see someone like you, and you have calcium in the coronaries, that it might be a situation where I need to treat you aggressively, because you never know when that heart attack could strike.
Right.
So if I know you have calcium in the coronaries, you're someone who I may want to get your LDL, not leave it at 130, not leave it at 110. I may want to get your LDL down to 70. So I may recommend going on a medication called a statin. These are drugs that lower the cholesterol. But again, the good thing about a calcium score, it will tell me someone who's at risk.
Right.
If I know you have a 0 score, then you're at low risk, and we could work more on diet and exercise and try to get it down naturally. If your score is 100, you could be at very, very high risk. And again, we do a score for this. So it's 0 to, I've seen people with scores of 5,000.
5,000, wow.
The higher
I was
the
going to
score,
ask you,
the
what's the
higher the
gradient between, what we're looking at here?
Now, so again, the higher the score, also age dependent.
Sure.
As you get older, so someone who's 70 could naturally have some calcium.
Sure.
And we look at it for your age and sex. So if you're you look like you're 35 years old, right? So for a young man like you,
Yeah.
we expect very, very low calcium. Now, this test is particularly good for women. And one of the reasons is, women are more difficult to diagnose. First thing, women tend to have atypical symptoms if they have chest pains, or like they have indigestion, they may have shortness of breath, they may have nausea. They're less likely to have the elephant sitting on their chest. So it's more difficult to diagnose in women. Women often present with their first episode of chest pain, could be their heart attack. So it's more difficult and in women, we always suspect it's a man who's having chest pain more likely to have a heart attack.
Yeah.
Heart disease is the #1 killer for women, so it's really important that women pay attention to it. Women tend to, if they have chest pain, men run to the hospital, okay? Women tolerate pain more than we do, and they're less likely to go to the hospital with chest pain. So it's really important. And the other thing is, all the testing we do, everything we do is all focused on men. So if we look at a risk assessment for women, they usually have a lower risk when we do the classical risk assessment, but they're still at risk of having a heart attack. So for a woman, doing a calcium score is very important. If a woman has a calcium score over 0, it's almost always significant.
Really?
So when I see a 40-year-old woman who has risk factors, and I'm very tuned into family history. If their parents had a heart attack under age 60, I'm very concerned about them. So family history is really important. If they have hypertension, if they have diabetes, smokers. These are things I'm very, very tuned into.
So with the family history, how far back would you go? Just the parents, or are you going to go like grandparents or further down?
Well, I'm interested in grandparents, uncles. The farther out you go, the less relevant it is. But certainly parents, brothers and sisters, those are most relevant. But sometimes grandparents are very relevant too. If they have a grandparent who had a heart attack under age 50, that's very significant.
Okay. So let me ask you about, let's stay on with women here first, and then we'll move over to the men. When you say chest pain, what have you, again, this is my interest in this whole space. What are you talking about? What kind of a pain are you going to feel? Like,
so it's not always classical. The classic episode, you hear about heart attacks, again, chest pressure, like elephant, radiating to the arms.
Okay.
Those are with sweating, shortness of breath. Those are classic symptoms. But again, women may have more subtle symptoms. They may just be nauseous. They may be lightheaded. They may just have slight chest pressure, not the severe
discomfort,
pain.
maybe a little bit.
Discomfort, but not severe pain. So again, it's the #1 cause of death for women. It's one of the things why calcium scoring is really. That's one of the reasons I like working in this facility, because I could see the patient, we could do blood work, and we could do the calcium score all in one setting. Which is very unique to have it all available.
And that really is the beauty of the facility here in Clark, is that you have all of this at your disposal, and all you do is just walk down the hallway. I'm speaking from personal experience because I'm also part of the cardiovascular disease associates here, and I've had that done as well, the calcium score, and it was so simple. You just walk down the hallway, and it takes about 5 minutes, not even that, and that's it, and you get this number here that really is life-saving. Really.
And I'm very surprised sometimes with the results. Sometimes someone who I have absolutely zero suspicion of, low suspicion, obviously I'm doing it for a reason, comes up with a very high number. The first time I did this test was with a 37-year-old whose score was 1,700. And really he just had asymptomatic symptoms. He wound up having a stress test that was positive. We did a cardiac catheterization at Morristown. It turns out he needed immediate bypass.
Wow. Tell our viewers what exactly it is, what kind of a test it is. Is it invasive, non-invasive? And give it to somebody who has no idea what that means, and somebody like yourself.
Let me go through this again. So a calcium score is a CAT scan. Is looking just at the chest and it's looking at the heart.
Looking at the
and
heart,
again,
okay.
we could see the outline of the coronaries, and normally when you're born, you have no calcium in the coronaries.
Right.
As you age, you develop plaque, and you may develop some calcification. The older you get, the more calcification. But if you develop premature calcification, that's an indication of plaque.
Right.
The more calcium, the more plaque. The higher the calcium score, the higher the risk there is of a heart attack. So this is a test you could have that would help predict if you're at risk for a heart attack.
Right.
So I find this very, very important when I see a patient.
Yeah.
If I get a phone call at night about a patient's having chest pain, if I know they have a high calcium score, I make sure that patient goes right to the hospital.
Right. Right.
So it's really, it gives you an insight into what their arteries look like.
Right. It just gives you more information to make that call if you did get
Make
that
the right-
call,
make-
or,
and also
down a pathway.
it also will help me decide this person's at high risk.
Yes.
I'm going to put this patient on medication to lower their cholesterol, lower their risk. I may do other blood work, genetic testing to see what the cause of the risk is. And listen, it's very helpful for the family. If I find someone with early signs of heart disease and they have an abnormal genetics, I make sure that family get tested. If I find someone who has familial hypercholesterolemia and they have children and the children have high cholesterol, we can actually institute treatment in children at an early age and prevent those children from having heart disease
Very
like their
interesting.
parents.
Yeah.
So it's really important. So really prevention of heart disease, and I started off as an interventionist. I did angioplasty, I did stenting. I went in the middle of the night to save someone's life.
Wow.
I find it, as worthwhile as fulfilling for me to try to prevent them from having a heart attack in the first place.
Right. You don't want to get to that point, as we see here. You don't want to get to that point and then you have some kind of an issue and it's too late because you never know when it's going to strike. You could be driving, you could be at home. It's not all going to happen right here in the office and you're around medical
I want to save those people too.
Yes, right.
I'm
Sure,
saving,
yeah, of
I'm
course.
saving everyone. But I like to prevent it from happening
Prevent
first.
as much as you can. So we have the calcium score as one test. We also have, I'm sure everyone was familiar with the classic stress test that many people have had. Can you tell us about that? What does that involve?
So again, we have lots of tools as cardiologists. If someone's having chest tightness, then a stress test is a really important test to see if the chest tightness is due to a blockage in the coronary. So in addition to looking at the anatomy with the calcium score, you could see when they exercise, is a blockage so severe that it causes strain in the heart. And that's also someone who could be at higher risk.
Right.
So that's something that we offer to patients too. A younger person, I probably wouldn't do that if they're asymptomatic. If someone's older, if they have chest pains or shortness of breath, I usually do a combination of the calcium score and a stress test. That combination gives me a really good clue as to what's going on with the patient.
What's going on with the patient. Now, I've had the stress test before, actually twice I've done it, and it's a bit of a rigorous test. I mean, if you've never done anything like that, get on that treadmill, and then you have the nurses saying, can you get your heart rate up to 160? Yeah, sure, okay, let's give that a shot. And they just raise the thing higher up, and you're pumping away, and the whole thing. It's an interesting test for those who are maybe not familiar with it. Again, it's on a treadmill and so forth. Now, if someone who may not be able to get on the treadmill and go through the whole,
Well,
is there another way
we
you
have
can do
other
it?
testing. We have other ways.
Yeah.
We have different types of doing stress tests. We also have, if someone has an abnormal EKG, they're very high risk, we made a test called a nuclear stress test, where we inject a small dose of a radioisotope that gets taken out by the heart. It will show us the blood flow through the heart. So again, we have other tests we could do. If a regular stress test isn't sufficient, isn't diagnostic, we could do either a walking nuclear stress test or a pharmacological stress test. This is getting very technical.
That's
now,
fine.
so-
That's fine. I'm good. I love science, so I'm just kind of geeking out on all
But
this.
again, my goal is trying to assess the risk. Again,
Sure.
it's everything about a patient.
Right.
You want to again, don't forget, it always goes. Every conversation with a patient has to touch on diet, exercise, weight loss, looking at stress reduction.
Right.
we live in a very stressful society, and
This is
stress
true.
has a
This
lot
is
to,
true.
has a lot
That's
to
right.
do with it too.
That's right. So let me just circle back with you. So women, we talked about the potential with the heart, with the tightness of your chest and so forth. Are the symptoms similar in men as well? I mean, will they exhibit similar symptoms, or
men can have
what kind of guy experience?
I mean, men
what is
can
that
have,
kind of-
listen, men can have atypical symptoms.
Sure,
and
yeah.
chest tightness for everyone is important. And women
Right.
can have classical symptoms
Yeah.
too.
Uh-huh.
So men can have also atypical symptoms.
Right.
They may just be short of breath.
Right.
They may just be nausea. So the symptoms, not every heart attack is an elephant on your chest.
Correct. Right.
It may be indigestion.
Sure.
It may be, I've had people who've had tooth pain, because when you have pain from the heart, it actually radiates to your arm, also radiates to your teeth.
Yeah,
I've
wow.
seen
See,
patients
that's
that went to a dentist
Yeah.
who was really having heart symptoms.
Wow. See, that's
So-
something I didn't know. That's
Yeah,
that's
you have to
interesting.
you have to really be aware of
Yeah.
everything. Again, a lot has to do with the person you're seeing. If you're seeing a 60-year-old man who smokes, family history, high cholesterol, and they're getting exertional chest tightness, you have a pretty good hunch that's really significant heart disease.
Right.
If you see a 25-year-old woman with atypical chest pain, probably not heart disease.
Right.
But again, a lot depends on what the substrate is of the patient. But again, that's why doing looking at the blood work, looking at blood pressure, and again for the right person, doing a calcium score. Now I wouldn't do a calcium score in a 25-year-old.
Sure.
Because at that point, it takes a while for calcium to develop.
Correct. Uh-huh.
But certainly someone over the age of 40,
Right.
I would do. In certain situations, I would do a calcium score down to the age of 32 maybe,
see.
if they have a strong family history
Right.
and their cholesterol high. But it's very, very helpful to decide if someone should go on a statin.
Yeah.
Now, if you have an older person who doesn't want to go on a statin, then if they have a 0 score, you might be okay just using exercise and diet.
Got it.
So again, the number is very important. And again, it depends on the age and the sex, how you assess that.
Right. So we know about prevention as far as exercise, diet, stop smoking. If
Stress reduction.
stress reduction is another big one. Like
sleep,
you said.
sleep is important.
Sleep is important as well, and get these different screenings, the calcium score, get your stress test if you're
Right.
into that.
If you're at risk,
If you're at risk to have
if
that,
you're at risk,
yeah.
consider having a stress test, particularly a calcium score.
Yes.
And all this is in conjunction with your primary care physician, be it a family practitioner or an internist.
Right. Now, as far as diet is concerned, Doc, what types of things should people look for to prevent something with this calcium and this cholesterol building up? I mean,
Well,
what
you
could
want to be on a more Mediterranean diet.
Okay.
That means you want to have more vegetables.
Yes.
And you want to limit and more fish.
Uh-huh.
Olive oil, nuts is good.
Yep.
And you want to have vegetables. You want to have colorful vegetables. The more
Yeah.
colorful, the better.
Right.
And you want to think of the meat you have. If you do have meat, it should be a small amount,
Right.
like the size of a deck of a card,
Right.
a deck of cards. And it's really the main course is the vegetables.
Yeah.
Think of the meat as really more the appetizer.
I see.
So,
Okay.
so you're not going to have a big steak.
Sure.
You're going to have if you're anything, a small piece of meat surrounded by vegetables. And you want to have, again, you want to eat healthy. You want to, limit your eggs. If again, particularly if high cholesterol, don't have lots. And there's some controversy with it. You should limit eggs and try not to fry foods. And if you use oil, think about using olive oil or you don't want to use any hard fats, anything like that.
Okay.
And again, drink lots of water, and just have a smart Mediterranean type diet.
Okay.
That's the best way to start.
Good. Okay, Doc, so we're going to wrap up here. If you can, just in like the last 30 seconds we got, just kind of let the folks at home know what would the big takeaways from what we just talked about, as far as what kind of surmise it up into.
Well, when it comes to prevention, you want to focus on exercise and diet first, and you want to be aware of what your numbers are, meaning your blood pressure, your cholesterol, if you have diabetes, what your blood sugar is, what your weight is. These are important, and you have to really think of yourself as this is only your doctor's responsibility. You have to be responsible for your own health in partnership with your physician.
Yes, yes.
And if you're someone who's at risk of heart disease, be it that you have very high cholesterol, strong family history, if you've had any evidence of heart disease in the past, if you've had a premature stroke or any disease of heart disease, obviously needs a cardiologist. But when it comes to prevention, the people who have a strong family history, have high cholesterol, these are ones that you may want to seek out, possibly seek out a cardiologist in conjunction with your primary care physician, and consider having a calcium score done to see what your risk is if there's evidence of coronary calcification. And that, along with your lipid profile, may help us guide how best to treat you.
Right. Okay, Dr. Robert Fishberg, thanks so much for joining us. A lot of great information here at the Atlantic Health System North Pavilion in Clark, and that's just a great resource for everyone that lives in Clark and the surrounding community as well. But it's so wonderful to have this amazing facility right here in our town that has all these great amenities and things, like we said, with the CT scan just down the hallway. Everything is in one place, so it makes it very convenient that you don't have to go to another location. And just fantastic having this facility here, and fantastic speaking to you, Dr. Fishberg. Appreciate your time.
And again, either myself or one of my partners, and again, it's a pleasure being here, and I love working in Clark. Thank you.
Wonderful. I just want to say hello to Dr. Prasad. That's my doctor.
Oh yes,
He works with you. Yes.
Dr. Prasad is my associate that works here, my partner that works here with me.
Yes, how to get to him, because I'm sure he'll probably see this and say, well, you should have said hello to him. So yes. Okay, Dr. Fishberg, thanks so much for joining us, and thank all of you for joining us as well.
Great to be here.